as we begin this masterclass series with the aim of strengthening our understanding of pediatric dermatology and enhancing patient care across Kerala. To formally welcome this august gathering, I invite Dr. Yashwant Kumar AM, Chairperson of the Dermatology Chapter of IAP Kerala, to deliver the welcome address.
Thank you, Dr. Reni. Respected Nandakumar sir, Balachandar sir, Arun Inamdar sir, Gopi Mohan sir, Smita madam, Binukutan sir, Dr. Reni, senior members and my dear colleagues. Good evening, everyone. A warm welcome to each and everyone present in today's platform to the inaugural edition of our bi-monthly webinar series, Dermatology Masterclass, a unique series intended to provide current and latest updates on common dermatological ailments we pediatricians come across in our day-to-day practice. We are planning to have similar webinar series in upcoming months also with some of the doyens in the field of dermatology as faculty who will share their expertise with us. Hope it will be a great learning experience for everyone. Beginning with my customary welcome address, I foremost extend a warm welcome to a charismatic president of IEP Kerala, Nandakumar sir, who will be formally inaugurating the first edition of Dermatology Masterclass webinar series. Hearty welcome to you, sir.
Thank you.
Next, I would like to welcome President-elect of IAP Kerala, Balachandar sir, a dedicated leader and a true IAPN to the core. A warm welcome to you, sir.
Thank you. Thank you.
It's a proud moment for me personally to welcome today's guest speaker, Arun Inamdar sir, my own teacher at my alma mater, Sri B.M. Patil Medical College, Vijayapura. Sir is a much sought of speaker in dermatology, both nationally and internationally. We are blessed to have you as a faculty in our inaugural edition. Hearty welcome to you, sir.
Thank you.
Next, I would like to welcome ever supporting and dynamic secretary of IAP Kerala, Gopi Mohan sir, who has guided us throughout in planning this series. This program would not have materialized without your help. A warm welcome to you, sir.
Thank you, Ashwin.
I also welcome Smita madam and Binukutan sir, who have been my predecessors in dermatology chapter and who have contributed significantly for the chapter in their terms. Hearty welcome to you, dear madam and sir.
Thank you.
Next, I would like to welcome the convener of Dermatology chapter, Dr. Reni, who have come up with this idea of webinar series and who has been working hard to make this series a success. Warm welcome to you, madam.
Thank you.
Success of any online program is reflected in the presence of audience who are passionate enough to learn more. We are happy to have very good numbers for inaugural edition. I extend a warm welcome to all the senior members and friends from in and outside Kerala who have made themselves free to attend today's program in spite of being a busy Monday. Hearty welcome to you all once again. Jai Hind, Jai IAP.
Thank you, sir, for your inspiring words and for your leadership in bringing this vision to life. It is now my privilege to invite Dr. Nandakumar MK, President of IAP Kerala, to deliver the inaugural address and inaugurate this bi-monthly webinar series. Nandakumar, sir.
Yeah. Good evening, all. Respected Chairperson, Dermatology Chapter, Dr. Yashwant Kumar, Convener, Dr. Reni, and today's Chief Guest Speaker, Dr. Arun Inamdar, our President-elect, Dr. Balachandar, our Secretary, Gopi, Binukutan, then other seniors like Parameshwaran sir, Purushothaman sir, Dr. Shinmi, and Dr. Smita, and other dignitaries on this platform, and my dear friends. At the outset, let me congratulate and thank our dermatology chapter for conducting such a very useful bi-monthly CME on common dermatological problem in our day-to-day practice. Because as you all know, we have a lot of dermatological persons we are seeing in day-to-day practice. They are before going to any dermatologist or to their first, as a first physician, that primary physician, definitely they are coming to you only. So you should know the basics. At least you should know when to treat, when to refer, and what to give and what not to give. That also very, very important. And among that, atopic dermatitis is one of the common things. One of the common, because we are, especially during winter, winter season, we are getting a lot of atopic dermatitis. Atopic dermatitis is one of the most common chronic inflammatory disorders in children, affecting quality of life, both child and the family. As you, from the newborn period itself start, and it is a real issue for the family. And over the past decade, our understanding of its pathogenesis evolved remarkably from a predominantly symptomatic approach to and with the emollients and the topical steroid to be targeted to the targeted mechanism-based therapy. Today, we are entering an era where treatment is no longer just about controlling flares, but about modifying disease pathways and improving long-term outcomes. To discuss this, today we have an expert with us. That is Dr. Arun Inamdar, to discuss on current and
Nanduma sir, you are muted.
Nanduma is muted. Oh.
okay. Here,
Yes.
yeah.
Yes,
With
yes,
these few words, I declare this online program inaugurated and wish all the best for this program. Thank you very much.
Thank you, Nandakumar sir, for those words and for your encouraging address. May I now request Dr. Balachandra D, President-elect IAP Kerala, to share a few words with us.
Thank you, Rani. Am I audible?
Yeah.
Yes, sir.
Yeah. So, respected President, IAP Kerala, Dr. Nandakumar, our faculty, Dr. Inamdar sir, our immediate past President, Dr. Riaz, our state leaders, Dr. Gopi Mohan, the chapter office bearers, Dr. Yashwant and Dr. Reni, our past state presidents, Dr. Shimi, seniors, Purushothaman sir and Parameshan sir, and all my friends. It's an honor and privilege for me to address this webinar, and I sincerely thank our president and office bearers Yashwant and Reni for giving me this opportunity. Dermatology chapter is doing a lot of activities since the last 3-4 years when Dr. Jose took over, and we had many modules followed by Dr. Shimi, Riaz. Everybody has done a lot of activities, and this we should thank our office bearers previously, Dr. Smita, Binukutan, and now Yashwant and Reni has started great guns with a very important topic and a very good speaker in Arun sir, Arun Inamdar sir. So with this, our association continues to grow through such meaningful academic activities. I am look forward to working together with all of you to further strengthen our academic programs and professional unity in the coming year. I thank Inamdar sir for his willingness to share his experience, and I am sure the session will be highly beneficial to all the participants. Thank you, Jai Hind, Jai Hind.
Thank you, Bala sir, for your excellent address and for your continued support. We now move on to the felicitation address by Dr. Gopi Mohan R, Secretary of IAP Kerala. I request Dr. Gopi Mohan to felicitate today's program.
Yeah, Renny, before I start, just one request. Designate one person to mute others. Others, when sir will start talking, it will be a lot of disturbances in the background. Okay.
Okay, sir.
Thank you. Sir, incoming President Dr. Bala, President of Dermatology Chapter Yashwant, Secretary Reni, Dr. Inamdar, who needs no introduction. I have heard sir talking, wonderful talk, very basics, and we have given him a wonderful topic which is of very much help for us practicing pediatricians. Yashwant and Reni are doing a great job. They took off from where Smita and Yashwant as a secretary has left off. I wish the chapter the very best, and I wish you all a happy learning. Jai Hind and Jai Hind.
Thank you, Gopi sir, for your kind words. It is now time to introduce our distinguished guest speaker. And to do the honors, I invite Dr. Smita Murli, Chairperson of Dermatology Chapter, to introduce our esteemed speaker.
Thank you, Reni. At the outset, let me wish and give you a heartfelt congratulations to Dr. Yashwant and Dr. Reni for this unique idea of the bi-monthly webinar series. It's a super duper start to the activities of the Pediatric Dermatology Chapter, and I promise you my wholehearted support for this venture. Then it's my honor and privilege to welcome Professor Dr. Inamdar sir, a doyen in the field of pediatric dermatology. He's an international figure, and I have been I have that blessing to hear to his speaks and articles, read his articles, studied his book. So there is a doyen in pediatric dermatology in India, and sir has been awarded Professor Surinder Kaur Award for Excellence as the best pediatric dermatologist of the Indian subcontinent 2025 by the International Society of Pediatric Dermatology. Sir has over 300 publications. He has contributed around 75 chapters and is an editor of 12 books. Sir is the member of the editor board of Pediatric Dermatology Journal USA. He's an associate editor of BMJ case reports and clinical case reports and Wiley Online. I think the Sir's experience in pediatric dermatology is so immense. I can't be putting it in words. And Sir is now Professor of Dermatology in SBMP Medical College and Research Center, Vijaypura. And Sir is also the Vice Chancellor of BLD deemed university. So it's my honor and privilege to welcome you, sir. I welcome you, sir, to enlighten us regarding the current and emerging therapies in atopic dermatitis. Welcome, sir, and over to you, sir.
Thank you very much. Are you able to hear my talk?
Yes, sir. Yes, sir.
Yes, sir. Yes, sir.
Okay. If there is any disturbance, please let me know so that I can take out my the headphone and talk directly also. Okay. First, let me thank the IAP Kerala for inviting me to be part of this wonderful thought process of understanding pediatric dermatology issues. I am thankful to Dr. Yashwant, who is our alumni also, for taking interest, and the Reni, the secretary, and all the team members of IAP. Well, I have been working in pediatric dermatology. That's fine. But I'm a chronic repeater in pediatric dermatology. I keep learning. And when Yashwant asked me, sir, can you talk on this? I told yes. In the process, can you hear me? Not an issue?
No, sir, I can hear you.
Yeah, some disturbance. So I agreed for this simply because I will also learn with all of you. Well, the topic given to me is the current and emerging therapies of atopic dermatitis. Well, our president, sir, was telling Nanda Kumar, sir, that you will be seeing a lot of such cases, especially more in the winter season, where the exacerbation is very much obvious, and the very classical presentations of various presentations of atopic dermatitis have been shown in this picture. This is what you see. Some overview: it is a chronic immune-mediated skin disorder characterized by recurrent eczema, pruritus, irritation, and secondary infections. Yes, it affects almost 15 to 20% of the children worldwide and significantly impairs the quality of life. And pathophysiology, if you just think why it is important, how you manage is the issue here with the pathophysiology. The first and foremost is the skin barrier disruption. Then you get the dysregulated cell-mediated immunity and the IgE-mediated hypersensitivity. And there is a genetic and environment factors which are playing in this. And the recent concept is the microbial imbalance also. So this is the classical picture where the chronic or chronically relapsing inflammatory dermatitis, which manifests usually in infancy and childhood and improves with the age. This is very important. And clinical manifestations occurs in 3 phases. Here are the very classical ones where you got the cheek being involved, the forehead being involved, and the headlight sign, which is just hypopigmentation of both the periorbital area. So these are the various manifestations which we'll be looking at. What exactly constitute infantile phase of AD is it lasts for first 2 years of age. Skin lesions mostly covers both cheek, scalp, extensor aspect of the extremities. This distribution is very important because it differs in infantile and then when it enters into the next stage. The lesions may be oozy, itchy in acute and scaly and itchy in subacute form. What is important as far as the pediatrician is concerned is when you see a picture like this, both looks like same. You may think, okay, it may be atopic dermatitis. When the nose is involved, since early childhood, there must be something, and with the photosensitivity, usually you will be dealing with fun photosensitive genodermatosis. And in atopic dermatitis, you do not find the lesions over the nose. This is small clinical per how in your BGOPD brand a case as atopic dermatitis. Then the childhood phase or the adulthood phase of the atopic dermatitis, the more the flexural distribution and scaly itchy erythematous plaques will be there instead of just acute oozy lesions. These are the flexures which I have shown you in picture, where all the flexures being involved. And in Indian scenario, especially the brown color like ours, sometime only if you see the first phase of the left side of mine, picture shows hypopigmented lesions, but you just manipulate, what you get is all the follicular accentuation. This is called as follicular eczema, more common in colored skin like ours, which may not be there in the other type of skins, the Caucasian or other things. So this is an interesting observation. If you just see the first slide, first picture, you may think, okay, should we rule out Hansen's disease because hypopigmented patches, you must test the sensation. But if you just manipulate, what you get is the follicular accentuation. This simple examination will take you to the diagnosis. And then, well, for academic purpose, there are criteria for diagnosis, more than 4 major and more than 23 minor. If you get 3 major or 3 minor, you will be diagnosing as atopic dermatitis. Many times you see the cheilitis, Denny Morgan fold, even just nipple eczema, cheilitis, food intolerance, white dermographism. So these are the various, even just dry skin, ichthyosis is also enough to have some minor criteria. This is for academic purpose, but you should know in a busy OPD how you can correlate, especially Denny Morgan fold, which are very important for diagnosis. And then disease presentation, I have told you a specific area distribution pattern differs. Some weak evidence suggests that oral antifungal agents could be helpful in subset of adult patients with predominant head and neck involvement. Probably they think malassezia has a role in that. It's very difficult to say why only initially it will be over the extensor and then becomes flexural. Okay, then how do you find out the disease severity? Earlier the age of onset, more severe atopic dermatitis. Presence of filagrine mutation is also important, but you cannot do everyday filagrine mutation test. If you just find the linear Palmar lesions, that is hyperlinear Palmar area, it almost suggests that the person is having filagrine mutation. Or if it is associated with ichthyosis or the dry scaly skin over the lower leg, what you call as ichthyosis vulgaris, which is also a minor criteria. So they also indicate filagrine mutation. Why it is important? Presence of filagrine mutation or these clinical manifestations you can predict that the child may develop a more severe form of atopic dermatitis for a prolonged period. So these are small clinical observations. And then all of you know the atopic march. Well, the atopic march is the natural history of atopic manifestation, which is characterized by a typical sequence of progression of the clinical signs of atopic disease, with some signs becoming more prominent while others subside. What exactly happens is clinical signs of AD, that is atopic dermatitis, predate the development of asthma and allergic rhinitis, suggesting that atopic dermatitis is an entry point of subsequent allergic disease. So as a pediatrician, so you have to think what these atopic dermatitis may end up with asthma or allergic rhinitis as an atopic march. These are the various the trigger factors like irritants, wool clothing, winter chapping, excessive heat, sweating, airborne allergens, food allergens, skin infections, stress. All these then can trigger the atopic eczema. Then how do you manage? The title itself is management. There you have written current and the old and current, or the existing and the current. But here I am going to be mixed so that you will understand better. Otherwise, compartmentalization will not give a correct picture. If you just put a diagram, what is available is topical, phototherapy, and systemic. And this diagram narrates that increasing toxicity of the molecule and increasing effectiveness in axis. So, simple molecules like topicals, well, it can act, toxicity is less, effectiveness is not much. So as you go more the severe, you have to use the systemic. I'm just giving you a small, there are many ways by which I can explain. Then what you have to do is, simple thing is regular emollient, liberal application of emollient, not only affected area, unaffected skin also. Then there are studies where as soon as you start around 9 months, 9 weeks itself, the emollient application continuously, the progression to the atopic dermatitis has been reduced. Some studies show.
Can I?
Hello? Okay. Avoid exacerbating factor. When you start this treatment, start with a low potency, increase the potency of topical corticosteroid, add sedating histamine, exclude or treat infection in the next phase. As the disease severity increases, you can also consider topical immunomodulators like topical calcineurin inhibitor. And at the end, if it is severe one, then you have to consider the systemic immunomodulators. If you want to think, what is important is, whenever you want to plan a treatment, invariably you have to plan the pathogenesis directed therapy also. As there is defective skin barrier, moisturizers repair skin barrier very well. And then there is a transepidermal water loss. So you have to use wet trap therapy or moisturizers, which can also reduce the transepidermal water loss. As there is inflammation, it is an inflammatory disorder, you have to use corticosteroid or calcineurin inhibitors. As there is immune dysregulation, probably injectable biologicals and a lot of monoclonal antibodies are being used. And even the infection, the colonization of Staph aureus is very much in atopic children. So I will tell you when to use antibiotics when I come to that, the complications. So if you think pathogenesis direct therapy, these are the issues which you have to address. If you just want to make what is the treatment flow chart? Well, always there is a non-pharmacological therapy which is very much important in the atopic dermatitis, and there is also pharmacological therapy. What are the non-pharmacological therapies? One is moisturizers, then the bathing additives like colloidal oatmeal or bleach in case if you want to reduce the staphylococcal colonization, wet trap therapy. These are the non-pharmacological therapies which all of us can, whether it is dermatologist or pediatrician or a pediatric dermatologist. These are basic. For any patient of atopic dermatitis, these should be given importance. Then you have got pharmacological therapy. One is topical therapy, systemic therapy, and then the phototherapy. Phototherapy is possible in institutions. And topical therapy, we have got topical corticosteroid. I will come to those things. Before I really go for the pharmacological therapy, non-pharmacological management is very important. Preserve the skin barrier by emollient and hydration. Avoid triggers by allergens and irritants. Modulate immune response naturally. Correct skin gut access of dysbiosis by using probiotics and prebiotics. And minimize the bacterial colonization by using the bleach bath also. So these are the issues. What is the basic treatment? This I will repeatedly tell you. Effective emollient regimens are the mainstay of the AD management. Regular use of moisturizers has a short and long-term steroid sparing effects and reduces the frequency of acute episodes. So continuous application, liberal application of moisturizer is very much important, and it should be used at least twice a day and should be more frequently used during acute flares. In Indian consensus treatment, where bathing daily in lukewarm water thoroughly but gently for not more than 5 to 10 minutes is recommended. You should not ask them to take continuous shower or anything, which can again reduce the transepidermal water loss will be there, barrier defect will be there. So this is for everybody, irrespective of whether I'm a dermatologist or a pediatrician. Then comes the topical therapies. We have got topical corticosteroid, topical calcineurin inhibitor, which you know as tacrolimus and pimecrolimus. Topical PDE4 inhibitors, that is crisaborole, it came, but it went because it didn't give much result. And new molecules like topical JAK inhibitors, ruxolitinib, is going to come in Indian market also. So this is the list. TCNI, which are tacrolimus and pimecrolimus. Topical corticosteroid, topical JAK inhibitors like tofacitinib. Then you have got topical crisaborole, which is phosphodiesterase 4 inhibitors. We have to use antibiotics because staphylococcal pollination will be there. The new molecules like tapinarof is also being used. Whatever is there, moisturize and moisturizer is the basic thing. These are the FDA approved therapies for AD, especially topical therapies when mild is there, but severe we have to add the systemic ones. The TCS, TCIs, crisaborole, ruxolitinib, roflumilast, tapinarof, these are the things. Again, baseline is wet dressing and moisturizer. This is very important for all of you. This I have put it as a site-wise topical. So it is not that you use whatever molecule, okay, steroid has to be used. No, all of you will know it. I will just try to remind you again. Scalp, low to high potency topical corticosteroid. You can also use topical calcineurin inhibitors. Eyelids, topical calcineurin inhibitor like pimecrolimus is most better than the tacrolimus, which is ointment one, whereas the pimecrolimus is a cream one. And then face, always use low potency topical corticosteroid. Otherwise, the side effects of the topical corticosteroid will be there. Then you can use topical calcineurin inhibitor like tacrolimus or the pimecrolimus. Palms and soles, little thicker skin. So you have to use little higher potency than what you use for the face, like low potency. Then you can also use trunk and extremities, again low to high potency. And anogenital area, something like face, again low potency, topical calcineurin inhibitor, more important. If you can remember this or print it in your clinic and keep it, this is the best way of using all these. That's why I called it site-wise topicals. Again, same thing, depending upon the area, which again I have just put it to remind you again. The weakest is hydrocortisone. The strongest is clobetasol propionate. This is very important for all of you. Clobetasol butyrate, which all of you write. I will also tell the name. Humazon is your very pet. All the pediatricians keep writing. That is butyrate. The strongest one, like tenovate and the other ones, the clobetasol propionate. So this is the range which you should think. I have given you the site-wise applications, how you can use it. Same thing again, I have mentioned it here. I added even the betamethasone propionate. Betamethasone valerate is the famous betnovate, which you should not use for the reasons all of you know it. And well, one more important thing, how much to use steroid is very important. 1 fingertip unit is almost 0.5 gram and it covers 2 palms. So they cannot just finish 1 15-gram whole one day only. So this is also important to reduce the HP axis suppression. If you use more potent one, it may also and land up in HP axis suppression. So one is weakest to strongest. I have told you which areas to be covered with weakest and which should be strongest. And rule of the fingertip unit is very important. And then some more word which I would like to teach you is the proactive therapy. What is that proactive therapy? What is the standard dogma in treatment of AD? It is to use topical prescription medication to areas of the active eczema involved skin only. However, the recent evidence indicates a role for so-called proactive treatment, especially in children who experience recurrent flare at the same body sites. If that is the case, when it is in flare up, you use it properly. When in remission, still you use it at least thrice a week, twice a week, once a week. This topical calcineurin inhibitor, by which you will be trying to prevent the number of AD flares and increase the time between the flares also. And also you will be saving the potential cost also, because if you use every day, the cost will escalate. And the one new drug, ruxolitinib, that's why I told you I will compare in the process itself. It is a new molecule which is going to come in India also, flexible disease activity driven. This is just different from the proactive here. This is called as needed approach. Here you don't have to apply in between. What is patients were instructed to treat areas with active AD and stop treatment 3 days after lesions clearance. And at the very first signs of recurrence, please restart the treatment. Okay, so this is how need-based, that is as needed, and proactive therapy. Of course, this all depends on the molecule which you use. This is one child where I used the moisturizer and desonide, a simple low potency steroid. So this is the result. Okay, then the new molecule is also there called as tapinarof. It has not yet come in the Indian market. It is effective in the treatment of atopic dermatitis in a diverse population of patients down to 2 years of age. What is important is, again, in the another molecule, which is non-steroidal. So people will be having a steroid phobia. Many educated, as soon as the child comes, oh, don't write steroids, sir. But they will not know how best you have to use, or steroid can be useful also and not useful also. And in their hand, it can become most useless also because of abuse also. So these are the molecules which are coming in the market for the treatment. Especially every new molecule is trying to be a non-steroidal topical medication. Well, if you just put it in a nutshell, which is some systemic review of the network meta-analysis, don't worry about, there are 68 treatments which they have reviewed. What was the thing was pimecrolimus, tacrolimus, and moderate potency topical corticosteroids are the most effective in improving and maintaining multiple eczema outcomes. So I have told you this, you have to remember what molecule where, size wise, not the body site wise is more important, and in potential also I have told you. So what is the instruction to the parents? pH matters, avoid harsh soaps and hot water, use lukewarm or cool water. Duration of the cleansing ritual should be limited to 5 to 10 minutes, and patting the skin as opposed to rubbing is also preferred. So how to apply moisturizer is also an important thing. As soon as bathing is done, or if you wash it, within 3 minutes, you should apply, not by rubbing the part and just pat it. Still, there has to be moisture. This moisture will be retained by these type of the moisturizers, especially 50% liquid paraffin or liquid, the white paraffin is the best one. Of course, there are new molecules like ceramides and all. I will not deal much because not much useful, only cost escalate. Simple thing would help you. And then coming to the systemic therapy, we have got biologicals, JAK inhibitors, and conventional systemic drugs. They have written in alphabetical order: azathioprine, cyclosporine, methotrexate, and systemic corticosteroids also. Okay, so there are FDA approved, like Indian market also has got abrocitinib, upadacitinib. We have got tupilumab also. All other molecules are not available. But if you come down, like immunosuppressant agent, methotrexate we have, azathioprine you have got, cyclosporine you have got, mycophenolate mofetil we have also got. So if you just ask me, conventional systemic drug, which is the best drug for, which you think is the best in children? Best is cyclosporine. Very severe, cyclosporine works very well. It is a rescue therapy, and it can be given into the children without much worrying about the nephrotoxicity. Am I audible? If there is anything, please let me know. Okay, and then oral JAK inhibitors. We have got abrocitinib, baricitinib, upadacitinib, and tofa. All these are NIBs. NIBs are the new molecules which are going to write therapy for many of the inflammatory conditions. Biologicals, dupilumab, lebri, and tralokinumab. But unfortunately, dupilumab is not available in India. You have to export from some other, import from some other country also. This is an interesting case where the child was brought by a grandfather. He was just telling, sir, he itches like anything. So this was the atopic dermatitis. This was in, yes, anything? Hello?
No, sir, continue, sir.
This was in actually the COVID era. That time it was available also and cheap also. Somehow it was made available for emergency purpose. I knew that I had read it. I told I will use one molecule which is not routinely given, but I will give you. Within 1 month, the child became all right, and itching subsided like anything. All these NIBs, tofacitinib, upadacitinib, are best in reducing the itch. And the very definition of atopic dermatitis is one more thing: itch, scratch, and itch cycle. So if we can reduce the itch, well, you have won the war almost. So this was used, and the grandfather almost held my feet. Sir, after giving that, within next day only, he was started sleeping without any disturbance. Anyway, these are the molecules which you can think. And then we have got abrocitinib. But unfortunately, these molecules are for adults more than 18-year-old with refractory moderate to severe atopic dermatitis. Baricitinib approved in Europe. India, it is not available now. If it is available also, I think it's very costly. And then tofacitinib is very much available. Now almost it is in dermatology, and I don't know how often you use it. It is almost replacing the oral steroids, something like that action only. But I don't advise you to use it. Well, very severe atopic dermatitis who fail to standard therapy can be treated with oral tofacitinib. I have used in little adolescents and all. More than 6 years of age children, I have used it 5 milligram once daily or twice daily, depending upon the weight of the patient. Less than 40, you can give 5 milligram OD, and more than 40, 5 milligram BD. Also, this is a good molecule. Well, you have to know it properly and then use it. Then upadacitinib, it's available in India, a very costly one. Again, it is children above or equal to 12 years of age. So invariably, what we get is in the childhood phase. And the one who are resistant to go in for adulthood stage, these molecules are useful. And dupilumab, again, but this is a good thing that it is now approved for children aged 6 months and above. It is a alpha subunit of IL-4 receptor. It binds to that, which is a part of both IL-4 and IL-23 receptor complex, which is an important interleukin molecule in the pathogenesis of atopic dermatitis, which I told you, the pathogenesis directed treatment also. These are all, if you really want to use it, well, you have to import it, and dosage schedule is given here. It is given subcutaneously, and it all depends 6 months to 5 years, what's the dose, 6 months to 17 years, what is the dose, and 18-year plus. You will be only dealing with 6 months to 5 years and 6 to 17 years. Well, if you really wish to have it, you have to import and then start. All instructions will be there. And what is more important is, unlike all other the MABs, the biologicals available, there is no biochemical or instrumental examination which are reported to be required for the monitoring of the therapy. Otherwise, all other, even NIBs or the other biologicals, for example, rituximab, you must be knowing all these things. You have to do a lot of pre-work and also the post-work also. If you just put it in nutshell, assessment, you have to have history, examination, all those things. First line, what you have to do is emollient, topical corticosteroid according to the severity, which I have told you. You can use sedating antihistamine like hydroxyl hydrochloride. And if there is an evidence of infection, antibiotics, especially, I'll show you, if there is elevation crusting, that is called as impetiginization, that suggests that the child is having overlying staphylococcal infection. Unless you add an antibiotic, the response will not be good. Then second line, you can use topical calcium inhibitor also. And then the relapse, again, same story. But if there is a continuous remission and severity is more, you have to use third line therapy. Like I was telling you, I use cyclosporin, I use methotrexate. These are the two molecules which I use, and I have not used dupilumab. Simple reason, it's not available, and cost is also more. So this lower part is dermatologist purview, but well, if somebody knows it, can always use it. There is nothing like a compartmentalization. If you just put it again, same thing, emollient, avoid allergens, and graded wise, depending upon the severity, you know the molecules now, how to use, you know it. So again, I have just pictured here, what is the yardstick flow diagram? Well, if you see a patient of mild or moderate, you have to use moisturizer, add topical corticosteroid, and then add crisaborole 2% ointment, which is I don't prefer much because it's not much effective. And these are the options for you. And if it becomes moderate to severe, well, you can think dupilumab or systemic immunotherapy like cyclosporin and methotrexate. Either you can use it or refer to the dermatologist. Well, you are asking what are the latest one. This is the picture which shows everything. I don't want to go into that. What I'm trying to show here is there is so much of research going on, and lot of what they are doing is new susceptible loci they are finding out, thereby targeted therapy without much side effects will be dealt. And in summary, if you just is a chronic relapsing inflammatory skin disease. Basic skin care with the skin culture and emollient with ceramides can reduce severity and prolong disease relief. And Syndet is an ideal and suitable cleanser in neonatal bathing. Well, it usually develops in childhood but can occur in adults. Management involves drug and non-drug treatment, that is pharmacological and non-pharmacological. Moisturize is important improving the condition of the skin. Topical corticosteroids are the main drug treatment. We must know what is site-wise. The choice of corticosteroid depends on larger on the site. And topical calcium inhibitors can be considered for sensitive sites such as face, where potent topical corticosteroids are potentially harmful. And you should use adjunctive treatments like bleach bath and wet dressings, phototherapy institutions where it is available. If you want to use systemic immunosuppressions, well, cyclosporin I rate as the best, and affordability and availability, dupilumab. And other nibs are not yet for the children. It is only above 12 years. So this is where sometime the question is course of the disease. What happens? A prospective study in cohort children followed longitudinally indicated that approximately 60% of children who developed AD by the age of 2 years had resolution of their symptoms, and by 4 years of the age, almost resolved. That means patient will ask you, sir, how long? So I always tell 3, 5, 7, 9. So this is how. And then those who have mutation in the filaggrin, I have told you how to recognize. Very simple. Palmar hyperlinearity, ichthyosis vulgaris associated. Well, you can predict that this child may develop a more severe form and also for a prolonged period. It may take resolution take more time. The message to treat anything is a great therapist is a sum of all he has seen, heard, thought, and read. Read is more important. Experience learning is also very important. And whatever I said and done, these type of webinars will make us aware what's happening, what we are doing is correct, or what we can do. A small change will bring a lot of differences. So I thank IAP Kerala and my friend S1, the President, sir, incoming President, and all of you for giving me an opportunity to learn again atopic dermatitis myself and share with you, all of you. Thank you very much. I thank and well, I wish this series to be a better one so that the understanding of pediatric dermatological conditions becomes more, and the benefit will go to the children who will be suffering. Thank you very much. Thanks a lot.
Thank you very much, sir. Thank you, sir. Yeah. Thank you, sir, for that lucid talk. You made it very simple and interesting. Thank you very much. I think over to Reni. I think there are some questions in the chat box.
Yes, ma'am.
Yeah.
So there are a couple of questions in the chat box. The first one is, what is the strength of tacrolimus to be used?
It is 0.03 and 0.1% is for adults usually. Or if the thicker skin lesions like lichenification we call, which is not much seen in children. So 0.03 is the best one. And I have told you also, it is an ointment one. It can cause sometime burning sensation. So if there is a facility of fridge in their house, you can ask them to keep it in a fridge and then apply it. It may reduce. Or if it is an open injury is there, any erosion or anything, it will burn. So that has to be told and kept in mind.
Okay. The second question is there any role for mometasone?
I have told you all the molecules I have just showed you, from hydrocortisone, which is the mildest form, to the clobetasol propionate. So I told you, I showed you a picture site wise. So simple: face, genitalia, least potent, and other areas, thickest skins like palms, soles, or lichenified lesions in the flexures. You can go ahead with little more clobetasol propionate, what you told them, the mometasone furoate, or desonite, what do we call. Those things can be used.
So the next question is, please explain wet trap therapy.
It is just a simple thing, like take a cloth, if it is a particular area. Sometime in Western countries also we can make here whole banyan like thing, which can be worn, and put water, and then they dilute with topical steroid, put another cloth, and again put little water, keep it for about 24 hours or even overnight. That acute ooziness and the severe itching will come down. And if there is an impetiginization, I told you yellowish crust suggests there is staphylococcal overgrowth, and you have to give simple anti-staphylococcal treatment. I prefer even cloxacillin or the with cefixime. It can use it. The another complication which I didn't, I had added somehow, I couldn't missed it, I believe. The eczema herpeticum. Sometime what happens is the herpes infection over which multiple vesicles will be there. Again, they also become the staphylococcal colonization increases. There, it is not only antiviral, you should also use anti-staphylococcal treatment also.
So the next question is, which soap to use to maintain the skin pH?
I told you, the Syndet bars, what do you call as Syndet bars.
And the next question is, can you suggest the time period for review or upping the therapy?
For any skin lesions, minimum 4 to 6 weeks. The answer is in the anatomy of the skin. The one from basal layer to the uppermost layer of the skin to renew, it takes 4 weeks, 28 days. So sometimes, interestingly, in Karnataka, they tell it increases during Amavasya and then comes down in full moon day. It is nothing to do with Amavasya and full moon day. These full moon and Amavasya comes every 28 days. So patient feels in one process, it comes on its own also, because renewal will be there, isn't it? So minimum 4 to 6 weeks to get a better response.
What is your experience with ceramide?
Yes.
Inamdar sir, one more question. Yeah. It is, what is your experience with ceramide?
Yes, I told you, ceramides are important when there is a filaggrin mutation is there. So we don't do regularly filaggrin mutation test. I told you clinical findings. I'll show my one palm. I don't know. If there are multiple hyperlinear marks like this, sometime only single lines or crisscross, this suggests that I am an atopic. These patients will also have some dry skin. We call it as ichthyosis vulgaris, which all of you know it. Fish-like scaling will be there. They indicate that the child is having filaggrin deficiency. Those are the patients where ceramides will work better. Otherwise, ceramides in moisturizers will increase the cost for the patients. Even your virgin coconut oil should work better. Simplest liquid paraffin should work better. Simple 50% liquid paraffin plus 50% soft paraffin. I shouldn't tell the trade name, but those are the best thing. As you increase the use of ceramide, and there are 11 ceramides, what you use are the synthetic ceramides, and the balance of ceramides in each disease differs. I don't know how many, what will put into the body. Do they really balance and then get it repaired? Okay, so I am just more economical prescription I wish to do, because simply one is more scientific, evidence-based. If there is a real evidence of filaggrin deficiency, I don't mind. If affordability is there, ceramide, why should we unnecessarily ask the patient to spend when simple things can give you result? But one interesting thing I would like, liberal use of moisturization is very, 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 very important. That's all.
Sir, one doubt, sir.
Yes.
Most mildest and strongest steroids.
Strongest is clobetasol propionate. I shouldn't tell the trade names. I will tell you 1008, Glaxo company. It works very well, but it is more strongest. That's why thick areas and areas where you, especially face and genitalia, especially children.
The mildest is hydrocortisone.
Hydrocortisone. And then is what you, all of you use, I know, pediatricians. Umazone is your pet, which is clobetasol butyrate actually. If you just change the salt to propionate, it becomes the strongest. That's all.
Oh. Hydrocortisone is the mildest.
Yes, sir. Yes, sir. For face,
hydrocortisone.
Otherwise, desonide, desoven lotion.
Thank you.
Madam, please.
Yeah. Sir, just I would like to know how good the remission is with the targeted therapies, sir. So using like tofacitinib and all, how good is the remission?
Very good remission. Why? Okay, because sir, I told you the very picture of atopic dermatitis by definition, it's scratch and each cycle. So you have to break that. Those molecules which are targeted, even cyclosporine, even all these nibs and the new development, that is the dupilumab, they reduce the itching first. I told you an example that almost
but the thing is, the costly thing, and that drugs are really costly. So like after two months and not, they're just.
That's very interesting, madam. That's why we are doctors. We should know how to economize the prescription. If you think you have given tofacitinib, then you should give only liquid paraffin. You don't have to write ceramide, which costs another 600 rupees. So you'll be reducing the cost. So I wish a lot of us should learn how to economize the prescription to reduce the burden. In the meanwhile, I also am a proponent. If the drug has to be used, he has to use it. For example, severe atopic dermatitis, I don't mind. The cyclosporine is costly, but it gives the result. And the child will be relieved of the problem in the shortest period of time. So if we have to force, this has to be used, means we have to use it. There is no other thing.
Thank you very much, sir.
Yes, sir.
Thank you, sir. Thank you, sir.
Sir, good evening. This is Dr. Hari Kumar. Sir, I have a question for you, sir. Thank you for the excellent talk, first of all. See, there are some secondary fungal infections usually we encounter in the treatment of atopic dermatitis. Apart from the pathognomonic lesions of atopic dermatitis, there may be some gray areas where we have to use some antifungals in the like dermatosis and all, when it is and some added fungal infections in the case of atopic dermatitis. So how to differentiate between these lesions of AD and the dermatosis, like topical, where to use topical antifungals in along with atopic dermatitis treatment?
Well, I just told you the areas where the neck, flexures, and scalp area, where there is a malassezia is prevalent as a normal commensal also. When they become pathogenic, we call it as pityriasis versicolor or malassezia furfur, which is causing folliculitis. Those things are there, or seborrheic capitis and then seborrheic dermatitis. So area is more important. There, if routine things are not improving, you know, if you use this, you should get the result within this, and this is how the patient should respond. And if it is not responding, addition of ketoconazole or any other antifungal topical should help you. But most important complication as far as infections in atopic dermatitis is concerned, it is staphylococcal infection. Yellowish crusting, well, the child has staphylococcal colonization, which has gone into pathognomy. And then eczema herpeticum, which I told you. And then even the areas where molluscum contagiosum, the viral infections, is also more common. So these are the things. Otherwise, I told you, expected result not coming. When you are used with a correct diagnosis, then you should suspect anything else I am missing. Those are the things which you can address, sir. I hope I made myself clear.
So what should be the interval, sir, when you use an Desanide or any topical steroid and antifungal? What should be the interval between these two topical solution, or I mean topical products?
One is you can use one in morning, one in night. That's all. And once you can stop after the desired result is concerned, the main thing has gone. So the pathogenesis has to be addressed. The pathogenesis, the atopic dermatitis. So you have to address with the topical corticosteroid or topical calcium inhibitor, or if you want to go further, systemic things also is there.
Thank you, sir.
Namaste.
Any other queries? We have some senior pediatricians from IIP Kerala. Purushothaman, sir.
Yes, sir. It is an excellent talk, sir. As a pediatrician, we used to get eczemas as a part of a systemic disorders like viscotality syndrome.
Yeah. Yes,
the complement
deficiencies.
So
primary immunodeficiencies with eczema as a presentation.
In that situation, is the presentation, distribution, or any way can you differentiate from the classical eczema? Is there any peculiarity of this eczema?
This is interesting, sir. This actually I should have added that the slide. I was answering to another colleague of mine there. If there are other associated symptoms, early onset of the lesions, and a family history of atopic things also should work. And again, it does not respond to the medications as expected. So those are the things you should suspect. And IgE level, if at all, not in all atopic dermatitis, IgE level, if there is a persistent, not responding to the routine treatment, more than 1,000, well, and associated multiple infections like repeated bacterial infection, repeated CSOM, repeated cyanopulmonary infection, maybe you are dealing with hyper IgE syndrome, where atopic dermatitis is one component. The other thing which you told, Viscott Aldrich, then there will be hemorrhagic component into the atopic dermatitis lesion. Then you have got the Langerhans cell histiocyte, almost look like that, but it's a seborrheic dermatitis. Again, there is purpuric component because you know the platelets are involved. So like that, it's a very interesting thing. A good clinical eye, over a period of time, you'll know this is not this is not responding, I should add this. So this is how we have to develop the clinical acumen. This is what I feel, sir. And it's a good question that we have to think, are there any syndromic manifestations of the atopic dermatitis? Are we dealing with them? So these are the other primary immunodeficiency syndrome manifestations, whether B cell manifestation, whether T or a combined. So you have to look into that. A simple B cell deficiencies, repeated infections, T cell, more of the viral or other things, the fungal infections. It's a simple analogy by which we can then. And then always a severe atopic dermatitis kept on increasing and not responding. You have to palpate abdomen, any organomegaly should give some clue that underlying things are different. So it's just how you keep observation is very important.
When sir was talking, I was reminded of hand-shoulder Langerhans cell disorders for which organomegaly.
Yes, I get.
Then
yes.
About as a pediatrician, we encounter more of we always talk about the asthma situations. We'll be asking about family history of asthma and eczema.
Yes,
and this eczema is so important as a family history also. In a
yes, very much.
where eczema and asthma coexist, it said that dupilumab will be working because we are
Yes, sir. Very good.
the
Asthma
other,
also they are promoting.
other monoclonal antibodies, but
Yes,
this
sir.
will be the choice when there is an eczema associated. And when you said it can be used even a younger age group because we
Yes,
cannot
yes. More than 6 months. More
other
than 6 months.
antibodies in a very young age group. This very.
Yes, sir.
Sir, what about the avoiding cow's milk? Is it recommended in all cases?
Not all cases, but these like peanut allergy, cow's milk, all those things are mentioned in literature. But obvious history, if the patient says that, well, we have to rule out all those things. But I would, if there are pertinent history is there, I would ask them to stop. Because otherwise, what happens? All this food allergy, very easy to say, don't eat that, don't do that, don't. Otherwise, the child has, or the mother, or the parents has to maintain a diary. Every day they have to write what was eaten. And every other day, whenever things were taken, is it going to affect it? Is it difficult task? But obvious things are, generally it is okay. Cow's milk, peanut, or allergy. I had a slide, but I thought it will be more to push everything in atopic dermatitis is a one-day affair. So I just made it, as the title was treatment, I just combined everything and told what has to be done as a basic pediatrician or a dermatologist, whatever is said and done. Baseline, this has to be done, how to use it, where to use it, how long to use it, when to refer, or these are the things available, at least well-informed pediatrician. This is what I was thinking, sir.
Thank you, sir.
Okay, sir.
Queries from the audience?
Sir, is there any role of using probiotics?
Yes, sir. I was telling you the dysbiosis is now everything is gut related, gut-brain axis, gut-skin axis is there.
Yeah.
And there are reports of using the probiotics also. There are no, I mean, well-designed RCTs where you can say proudly, okay, you must give this. So these are all additives. Unless the basic pathology, I showed you one interesting slide, pathogenesis directed treatment. So you have to address that. What other things we are doing is just supplementary. But it does work. Reports are there. If you ask me question, do you use it? Not often. Are there any, even there are reports that there are things are coming like topical, the probiotics also, but I don't know when really it makes sense. But the whole thing, new things, what they are coming is all these NIBs, JOC inhibitors. They are the molecules of the another 10 years. I don't know when new things will come, and all the biologicals and topical steroid phobia. Oh, other than steroid, what non-steroidal can be used? So this is what's happening in atopic dermatitis. And without forgetting, I'll repeat again, moisturizer, and moisturizer are the best baseline, and the correct use of topical steroid, no phobia, but correct use. And when to, I told you two good things. One is proactive therapy. Okay, treatment is, disease lesion is over, forget it. No. We can ask them to apply to those areas where the recurrences are common. That is proactive therapy. When the new molecule comes, ruxolitinib, well, they as and when also is there. But already in Indian scenario, people, even if you tell every day, they will apply as and when, or when the lesions comes down, they will stop. That also is there. We also know already our people know need-based treatment. Well, but still as a medical people, evidence-based, or it is our duty to keep on educating and modifying treatment modalities with the patients. Well.
Thanks. Yashwant, if we don't have any more questions, we can wind up.
Yes, sir. I think it was a really enlightening session. the first session, the inaugural edition, actually we could see 100+ participants in the platform, and I think few might have joined in the YouTube also. So I just want to thank once again Arun Inamdar sir and all the members who had joined to this meeting. We'll be coming up with similar webinars in future also. So to propose vote of thanks, I invite Dr. Reni Joseph, the convener of Dermatology chapter.
Good evening, everyone. On behalf of the organizing committee of the Dermatology chapter, it is my privilege to propose a vote of thanks. I sincerely and wholeheartedly thank our prolific speaker, Dr. Arun Inamdar sir, for an illuminating talk and for taking us through the clinical features and treatment of atopic dermatitis, and for the excellent discussion points. I'm sure all of us learned many new things about managing atopic dermatitis. Thank you, sir. I thank our state leadership, Nandakumar sir, Balachandra sir, Gopi Mohan sir, and Bidukutan sir, for all the support and guidance and for being with us throughout this session today. I thank Dr. Smita Murli ma'am and Bidukutan sir for guiding us in initiating this bi-monthly webinar series. And I also thank our chairperson, Dr. Yashwant Kumar, for all the superb efforts taken in organizing every small detail of this webinar. I would like to thank especially our participants. More than 100 people joined us on Zoom today for their overwhelming response and for joining us for this first edition of the Dermatology Masterclass, and also for that excellent discussion that happened. Thank you all. Jai Hind, Jai IAP.
Thank you. Thank you very much.
Good
Thank you.
Thank you.
Good night.
Good night.
Thank you.
Good night.
night.